And we're just going to finish up with a Q&A until 3 o'clock. So if you have any questions, this is your chance. And Audrey, my colleague, again, is going to be going around. So we'll start, Audrey, back here.
I'm sure everyone's curious, like what part of integrative medicine is, or all of these wellness applications are covered by insurance, and is that changing?
So what I heard was what part of, say, integrative medicine or other activities are covered
Can you hold
by
it?
insurance?
Sorry, can you hold it closer?
Sorry. So the question was really about insurance coverage for things like integrative medicine and rehabilitation activities. So for integrative medicine, someone was asking me as well. Unfortunately, it's really hit or miss depending on your insurance. So acupuncture is gaining traction. So I think Medicare officially covers acupuncture for low back pain. When I was in Ohio, I actually started covering it for headache. I think on the West Coast, it's varies state by state as well. But you should inquire with your insurance companies. I know some companies, like I heard Kaiser out here, actually for their employees, they do cover things like acupuncture. I would say massage and meditation yoga is probably less well covered. But I think over time, you're going to see it increasingly covered because of the evidence is growing. So, but definitely inquire with your insurance, and sometimes they'll cover, say, 10 or 15 treatments a year for different indications. And I'll let.
Insurance is definitely challenging. I'm currently working on kind of gathering intel from, the people who have been practicing in the area a little bit longer and have an understanding of which insurances work with which therapy centers. And, if, say, physical therapy isn't covered or there's difficulty getting occupational therapy, well, I have some friends, wink, wink, you can come talk to me and I'll see what I can do in terms of getting you some form of rehab and guidance for their needs. We'll find a way together.
I'm wondering how you feel about cannabis, and have you talked to patients about using that?
I think that one's for me. Cannabis. I figured it would come up. So, there is some data around cannabis for certain indications. So many patients don't realize Marinol, which is synthesized THC, or dronabinol, is FDA approved for things like appetite and nausea. And so, forms of it are out there. Now, in Canada and Europe, it's more widely available. There are other forms of cannabis approved, nationally. There's growing data that it may have some benefit. So the National Academy of Sciences and Medicine published a review article, I think maybe 3-4 years ago, where they talked about, there's growing data around certain pain, muscle spasticity as well. I think that the NIH is actually realizing they have to help with the research, because it federally it's still Schedule 1, which means it's in the same categories like cocaine and LSD, which is theoretically has no medical benefit, but we're realizing there's data to say now there is probably benefit. And so we'll see if there's going to be national legislation to change that. Of course, in California, it is approved both medicinally and recreationally. I do tell patients that there's enough data to say that it might be reasonable to try either THC or CBD and THC for things like appetite and pain, management. I think there's some preliminary data might be helpful for things like sleep or anxiety, but I think we need to do more research. I will say I actually got a R21 NCI funded grant to do a pilot study of CBD versus CBD plus THC versus placebo for chemotherapy-induced peripheral neuropathy. So I think you're going to see NIH, and actually NIH is really pushing for more research, including the NCI. So I think you're going to see more federal funding in this area so that we can grow the research base to have us have a better understanding of cannabis and its potential benefits as well as risks.
Hi, my question is for Dr. Krishnan, and it's like kind of basic question as far as whether or not remission has been reached. So my husband is 1 year post-transplant. He had in August of 21, And soon after that, his light chains were kind of just, they weren't skyrocketed. They came down quite a bit, but they're still above the range where the doctor wanted them. He has no M spike right now. Does that mean that he's in remission? Our doctor does not like to use that word. So we kind of just have what they called a stable response from the transplant team, but we're not quite sure if remission is where he is. We hear the word, but we don't know whether or not that's where he's at.
So, I think just in general, to make it a more general question applicable to everyone, what I could say is that there are set definitions of remission, and it's pretty easy to look up. I don't know if you have it as part of the HealthTree curriculum as a link too, but you can look up International Myeloma Working Group a response criteria for myeloma. And you can literally, there's a table and you can look and say, it says, this is the definition of complete remission. It lists the factors you need. This is the definition of partial remission. This is the definition of minor remission. And this is the definition of stable disease. So it's pretty easy. You can go through it and you can look and literally figure it out from there.
Thank you. This is probably related more to the first session, but as it was being talked about, maybe not necessarily advantages of using MRD testing to determine deep remission status. Wondering about, I've heard about the BCMA monitoring blood tests, that's in a study, and just wondering if that's going to be a helpful tool, especially thinking about becoming non-secretory, and wondering if that will be helpful.
So, there is measures of soluble BCMA. We've tended to use that more in CAR T-cell therapy, and we're interested in it to see, does that affect response to CAR T therapy? The question about using it for people who don't have measurable standard protein, I think in a way, to be honest, it's going to not be as useful eventually. Number one, it has to be validated in large numbers of patients compared to other ways of testing. So that takes a while and hasn't been done yet. The second part is really, there's a different way of measuring protein in the blood. It's called mass spectrometry. So the Mayo Clinic actually has changed completely, and they don't do the traditional electrophoresis anymore. They've moved everyone to mass spec, and mass spec is much more sensitive, including picking up people who we thought were traditionally not making protein by regular methods. So I actually think it's much more that we're going to all end up, we're actually looking and trying to get mass spec at City of Hope as well. And I think more and more centers are looking at that.
Hi, I have a question for Dr. Chang and Dr. Lee. So I'll ask both. So for Dr. Chang, my question is, especially for a lot of bone damage, for some myeloma patients, are when you're referring certain exercises or physical therapy, are you reviewing the MRIs, and like CT scans, and, to look at where the lesions are for certain types, of exercises or physical therapy? So that's my first question for you. And then do you want me to wait before she answers to ask the question for Dr. Lee? Okay. So we'll wait.
Yeah, that's a really good question. And yes, I definitely look at imaging. There may be, for example, back pain is very common. There may be a lesion there, but the question would be, is the back pain due to that lesion, or is it myofascial pain, or is it something else? Is it in the right spot? And so kind of identifying what the pain generator is very important, and imaging is definitely a consideration. And the second part, how does that, in terms of prescribing exercises, working with physical therapy. So I work very closely with the therapist, and I would have to, do in-services or talk about weight-bearing precautions if that's necessary, how much pain is there, which movements put force on, say, the leg, like if you go upstairs or walking, that's weight on it. And then if you add weights in your arms, that's putting even more weight through it. So certain exercises, like closed chain exercises. So, in the gym, sometimes people like to do their legs. They're on a seat like this, and there's a plate, and they're doing squats, kind of seated. That's a closed chain exercise where you're jamming your femur. And so with forces on both sides. And so if there's a bone lesion at the femur and it's causing pain, the more you push on it, I would say stop that exercise. So being aware of what type of exercise is doing what, putting what forces on the bone where the lesion is, and figuring out, is that the cause of the pain, or is it something else that we can treat?
Okay, and my next question, Dr. Lee, when I had never heard of an integrative medicine doctor, so now after your presentation, I'm wondering, as a doctor, are you reviewing a patient's all of their labs, like other parts, like you were talking about, their heart condition or liver condition, or how are you, all the other possible comorbidities when you're trying to integrate medicine into their myeloma care?
So the question is about how much you integrate kind of all their other comorbidities and other laboratory workup, medical workup that's been done. Absolutely. So as much as possible, I try to look at everything that's available in the chart. Try to look at everything that's available in the chart, including, liver function, kidney function, what kind of treatment are they receiving? Are they stem cell transplant patient or not? And then, do they have other comorbidities that might be contributing to the different symptoms that they're having? Because I do, it's kind of like Dr. Chang was mentioning, he's like trying to think about whatever the symptom is, what's the root cause of that? I don't want to just, if they have pain, I don't want to just treat the pain with acupuncture. If it's really related to, a bony lesion that might be about to fracture, well then, maybe that patient needs radiation. We can use acupuncture to treat pain, but ultimately they need radiation to that spot to help, treat the cancer itself. So yes, we want to try to look at all aspects and really get to the root cause.
I found out that when I have lower back pain, if I lay down on my back and lift my legs up straight, pain will go away. And if you do that every day, you won't have lower back pain. And from that, you lift your legs up and you can walk or spread them out, do all kinds of exercises from that. And it works great.
What do you think of that?
I think that's a wonderful comment, and let me extrapolate a little bit. First, there's many different reasons for back pain. It could be cancer, it could be the muscle, it could be the core weakness, it could be the facets, the discs, it could be a radiculopathy, a nerve impingement, stenosis, cancer. There's so many different reasons. What he's pointing at, that exercise of lifting your legs, that activates the core, which is commonly not toned. And when that is more toned, it allows your back muscles to relax. And so I would suspect that his type of back pain might be because of, myofascial, like muscle tightness. And so when he activates his core regularly to tone his core muscles, he finds relief.
First, I'm trying to figure out how to make sure that this turns into a question and rather it's compared to a comment, because I'm like jumping up and down with joy to hear what you guys are saying. And it's also a plug for HealthTree, because it's not until I got involved with HealthTree, and I'm one of the early ones from 2018, from the summer tour, that things like diet and integrative medicine and physiatry, whatever we're calling it today, which is totally new to me, until I really became aware of that because I've been reaching out to doctors for years. I'm a 15-year survivor. And I would say once I got past like 7-8 years, I thought, shit, I'm not going to die of this that quickly. And it seems like I'm hanging in there. And so now, like, what do I do to make sure that I die? I made this comment to somebody earlier. I think they thought I was nuts. I want to die of myeloma. I don't want to die of heart disease or diabetes or, crack my back or whatever. And that might sound really bizarre, but I think it expresses that I want to keep myself as healthy as possible. So I obviously I am making a comment and I apologize, but so you guys are up in Orange County, and this is how I think I can bring it into a form of question. I have searched in San Diego. I have gone to somebody who's supposedly integrative, and I've gone to somebody else, and the resources are so thin. It's what you guys are on. It's amazing that you're cutting edge. Like, how can ancient Chinese medicine be cutting edge? Like, how bizarre is that? But it is. And it's very, very hard to find the help. So the specific question, if I ever get to it, is there value in perhaps doing a consult with each of you? I can drive up to Orange County and do that, but it's not practical that I'm going to come up every week and see you there. So what kind of mechanisms, if any, have you got for a one-time or two-time or whatever consult that we can then take back? And now that I know exactly what I'm looking for, now I can figure out, or maybe with your help, how do I get it in San Diego? Or how do I get it in Podunk, Iowa, or whatever? Is that a fair question to take my comment from?
Yeah, no, I think that's a very good question. I agree. I think probably both for integrative oncology and for, cancer rehab, there's probably not enough physicians who are trained specifically in this area. So it's hard to get, see someone as specialized as we are in every part of the country. So I think it's just like seeing an expert like Dr. Krishnan for a second opinion. And I see patients from far away from San Diego and other areas who want to have an integrative oncology consultation. And then I can try to help them think about things they could do on their own. With the pandemic, a lot of things are online now. So there's a lot of other options you can do on your own. So we're happy to help see patients. I do see patients in Duarte as well. And then we are going to try to grow our program. And as you probably heard, City of Hope is really growing, with Orange County, and we also have acquired Cancer Treatment Centers of America. So Chicago, Atlanta, Phoenix. So we're really trying to get our services to as many parts of the country. And so I think you're going to see both integrative oncology grow, cancer rehab grow, and be able to offer, services at more than just the main campuses, and try to get it out to the community as well.
Yeah, I think it's a great point that you pointed out that access is a big issue. And for cancer rehabilitation fellowship trained physicians, I'm the third one in Southern California. A few years ago, there was one. And so it's very shocking given how much, even today, you saw the hands raised, how much perceived need there might be. And, I'm one person. So right now we are seeing consults in person. And depending on the issue, some people with more physical issues, like I cannot do deep tendon reflexes, do the knee jerk, like virtually. But there are a lot of things we can do virtually. And so right now the system is, at least one in person, and we have mechanisms to follow up by video. And one of the things I like to think about is who is around you, what resources are around you, so that you can see someone in your area to make it feasible for you. And I would try to contact my network, my professional society, and do whatever I can to try to direct you to the right place.
One more question for Dr. Krishnan about the Revlimid medication. So this is actually a question coming from my husband. So he's concerned about the reaction to Revlimid to me as his caregiver and his wife. Now we've discussed this with our doctor before about whether or not Revlimid is harmful to me through sexual activities. And she has said that it was fine, but in research, he has, seen a lot of different takes on whether or not it's dangerous for me, since we're in our 40s and, with an active sex life coming out of transplant a year now, he's kind of concerned about that.
So let me let me go a little bit back into the history of what Revlimid is. So it actually came from a drug. Initially, it was a drug called thalidomide. So thalidomide was used, I think, in the 60s or 70s, and it was given to pregnant women, I think, for nausea. And what happened was babies were born without limbs. It's called phocomelia, and they found it was from thalidomide. So obviously the drug got withdrawn. It suddenly got reintroduced. There's actually a treatment for leprosy. And then it was used actually in Arkansas for a patient with very advanced myeloma. And lo and behold, this patient was going to hospice. And, I know one of his doctors on his team, like, oh, it couldn't hurt. It's a pill. Why not? The patient's wife actually did the research. And lo and behold, it worked. Things were a lot easier to get trials done then. So they did a trial, got published in the New England Journal showing thalidomide worked for treating myeloma. Now, the FDA did say, because of the history of thalidomide, we will allow it to get back on the market. But as you will all know, you can't just get a prescription, go to CVS and pick up your thalidomide. It's given through a program called REMS. And REMS isn't just for thalidomide. REMS is also for CAR T cells. It's for teclistamab. It's a program that maximizes benefit and tries to minimize risk to patients. And so I don't remember what the REMS stands for. Forgive me, but what that means, so every drug that's in a REMS program, there are different rules for the doctor and rules for the patient. So Revlimid, being in the same family as thalidomide, follows the same REMS program, which means that patients have to take a pregnancy test each month, or they have to agree to using 2 forms of contraception and sign a contract. As many of you know, you have to take the online survey as well before that drug can get dispensed each month. So those are the rules for prescribing that drug. Those are pretty steadfast rules. So,
And we're nearing the end. I'm going to ask 2 online questions. One of the points about a roundtable is that it's basically a one-room classroom. We've got experienced seniors and we've got first graders and we've got everything in between. And so no question is a bad question, but this is an important one, especially for the newbies. What's the difference between multiple myeloma and extramedullary disease? Are they 2 different diseases? Do you treat them differently?
So yeah, I think that just speaks to how unfortunately we're bad at terminology and make things confusing for patients. So medulla is basically marrow. Extramedullary means disease outside the bone marrow. Multiple myeloma just speaks to that myeloma is usually throughout the body. You don't always see it throughout the body, but multiple sites of disease. Extramedullary just means that there can be sites of myeloma that are outside the bone marrow. That's it.
And then one final question. This is for Dr. Krishnan. Have you ever had any experience of treating a patient who reverts back to an MGUS-like state after therapy? And if so, what does that tell you?
So absolutely, there's this phenomenon where we have patients who still have a persistent M protein, usually very low levels, that just lingers for years and years. And I have patients like this. I have someone who actually, if I think about it, she had a transplant in 2003, relapsed, got Revlimid, which actually wasn't FDA approved then, got it on a trial at Cedars, and then actually went off of it for because it was a trial, it stopped, hasn't had any therapy, but she still has an M protein of 0.1. She's had that for probably over a decade. So she likely has gone back into this MGUS state. The problem is you don't know it until you have the luxury of hindsight. And so we do know that there are such patients, but we can't identify them up front.
Thank you. One of the, for all of you in the, when putting together meetings like this, it's just as important to figure out what you're going to leave out as it is what you're going to talk about. We left out a lot today, and you are still overwhelmed, I bet. And especially if you're a newbie, you're really overwhelmed. So in that case, I'm always available. Jenny's always available. Everybody in our staff is always available. You can always call us. And if you have questions, and we have professional people that will help you. So if you find that you only understood 10% of what's going on today, you are 100% ahead of your peers. And so that's very, very important. My last word is, when I began working in myeloma in 1998, there were 40,000 Americans living with myeloma, and most of them were not living very well. In 2017, there were 120,000 Americans living with myeloma. Based on the projections that we could figure out, we figured by the end of this year, that would translate to about 170,000 Americans living with myeloma. Now that we've re-looked at the statistics that have come out from the National Cancer Institute, there are an additional 20,000 Americans living every year with myeloma moving forward. That's an indication of how good the therapies are and how they're getting better and how that number is going to increase. So instead of 170,000 Americans living with myeloma at the end of this year, there are more likely 220,000 Americans living with myeloma this year. So the news is good in the aggregate, in the big picture. In the small picture, you really could care less about that. But just remember, the big picture is good, and we are trying to get you into that as much as possible. And that's what these meetings are about, to get you to understand, not to be an expert on myeloma, but that you have enough information to ask the right questions of your healthcare teams when you go in. And with that, I'm going to turn over the last word to Jenny, and Jenny will conclude the day for us. Thank you.
Well, I just want to thank you for coming today. And I want to thank these amazing doctors. Can we give them another hand? Thank you for spending your Saturday with us and being cold in this room. But thank you for your amazing information. As you can see, people who specialize in multiple myeloma have a unique skill set. So please, please, please search them out and use them when you're diagnosed, when you're trying to make a treatment decision, and it'll just make the biggest difference for you. So thank you again for coming. We appreciate you all.